Pleural effusion is the buildup of fluid within the pleural cavity. The pleural cavity is made up of two layers, the visceral and parietal layer. The visceral layer is a layer that is directly connected or on the lungs itself. The parietal layer is the pleural that covers the internal surface of the thoracic wall, the superior diaphragm, and the lateral surfaces of the mediastinum. In between the visceral and parietal layer is the pleural cavity. This normally has about 20 cc's of fluid and helps with lubrication. Pleural effusion is when this fluid builds up, which can be caused by too much fluid accumulating in this space or not enough fluid being evacuated from this space. The first example of pleural effusion is a transudative cause. This can be caused by 1. Increased hydrostatic pressure or a decrease in oncotic pressure. Most common cause of increased hydrostatic pressure would be heart failure, and the other cause of decreased oncotic pressure could be liver failure or nephrotic syndrome. With heart failure, the fluid backs up into the pulmonary capillaries. This causes increased pressure within that capillary and then pushes fluid into the pleural space. The other cause of transudative pleural effusion is the loss of oncotic pressure. With the loss of oncotic pressure, fluid moves from the capillary to the pleural space due to the process of osmosis. The two most common causes of this, again, will be liver failure and nephrotic syndrome. The next cause of pleural effusion is an exudative cause. An exudative cause is caused by an inflammatory, infectious, or malignant etiology process of the capillaries. When this occurs, the capillaries become more leaky, and this allows for fluid, immune cells, and other proteins to leak out of the capillaries. This can be caused by pneumonia, viral infection, malignancy, and more. Another cause of pleural effusion would be a chylothorax. This occurs when the thoracic duct is disrupted. Some of the causes of a chylothorax would be trauma or thoracic surgery. This can also be caused by tumors in the mediastinum that are pushing up on the duct itself. The thoracic duct is one of the largest lymphatic vessels and drains lymph from most of the body. The lymph that it's draining appears milky white in appearance because it contains chyle, which is a product of digestion. That is why this effusion will usually appear white in appearance and have a high level of fat. Some of the signs and symptoms of pleural effusion can be shortness of breath, decreased breath sounds, decreased fremitus, which is the vibration heard with talking, dullness to percussion, and chest pain. This chest pain is known as pleuritic chest pain or pleurisy. This is caused by inflammation of the pleural layers themselves. Another symptom, though infrequent, is pleural friction rub. This is the sound of the pleural layers actually rubbing against each other during inspiration and expiration. This sounds like a harsh grating or creaking sound. Again, remember that pleural effusion is usually secondary to another disease process, so there can also be symptoms that help you decipher the cause, as in transudative and exudative. When diagnosing pleural effusion, the patient history can be very helpful. Again, that's because pleural effusion is usually caused secondary from a disease process. So patients most likely to have a transudative pleural effusion would be patients with a history of cardiac, renal, or liver impairment, whereas a patient with a diagnosis of pneumonia or a known malignancy might have an exudative pleural effusion. It's important to understand and know this, that patients with a pulmonary emboli can have both a transudative and exudative pleural effusion. When looking at radiology, chest x-ray can be helpful in the diagnostic of pleural effusion. When we're looking at the chest x-ray, we're looking for blunting of the costophrenic angles. This can be difficult as there needs to be a sufficient amount of fluid or effusion within the pleural cavity to have this. However, there can be enough pleural effusion to have blunting of the diaphragm contour and elevation of the hemidiaphragm. Other useful and more specific diagnostic criteria would be ultrasound and CAT scan. Another helpful tool is Light's criteria. Light's criteria is taking the pleural fluid from the pleural space and looking at the LDH and protein count and comparing that to the LDH and protein count within the serum. How that is done is with a thoracentesis. I should add that a thoracentesis can both be a diagnostic and a treatment option. When looking at Light's criteria, there's 3 criteria. It is the pleural fluid protein to serum protein ratio. If that is greater than 0.5, it is most likely an exudative cause. The next is pleural LDH to serum LDH ratio. If that is greater than 0.6, it is most likely an exudative cause. Last, it is pleural LDH is greater than 2/3 upper limit of the laboratory reference. I should add that only one of these needs to be met in order to be a high likelihood of an exudative pleural effusion, not all three. How that happens is there's a thoracentesis from this pleural space. As you can see in this pleural space, most likely being an exudative cause, there's a lot of proteins and LDH and other things in that area. That is then drained, and you look at the LDH and protein count. Then there is a lab draw from the blood and looking at the LDH and protein from that side. Treatment of the pleural effusion needs to be focused on the pleural effusion, but also the disease etiology that caused the buildup of fluid. You might, for instance, give diuretics for heart failure or antibiotics for pneumonia. If the pleural effusion is large enough, then a thoracentesis might be done. This thoracentesis, again, can be both diagnostic but also a treatment modality. By getting off the fluid from the patient's chest, it should help relieve some of their symptoms. Some other things that can be done are a chest tube, a pleural drain, or a pleural desis, where the provider injects a medication into the pleural space, which causes irritation of the visceral and parietal layers. Therefore, this irritation helps the two layers to form together. Therefore, there is no more space for fluid to accumulate and hopefully no more pleural effusions to occur. In review, pleural effusion is the accumulation of fluid in the pleural cavity, which is caused by too much fluid entering the space or not enough exiting the space. The major causes are transudative, exudative, or a chylothorax. With transudative, we either have an increase in hydrostatic pressure, which we see with heart failure, or a decrease in oncotic pressure, which we would see with cirrhosis. As far as exudative, there's an inflammatory process which causes the capillaries to leak fluid and other proteins. Chylothorax is usually when the thoracic duct is disrupted. Signs and symptoms can be shortness of breath, dullness to percussion, decreased breath sounds, and pain with respirations. Some of the diagnosis ways we can figure out a pleural effusion would be a chest x-ray, ultrasound, and CAT scan. Again, Light's criteria helps us to figure out which type of effusion we are dealing with. Lastly, treatment can be thoracentesis, chest tube, pleural drain, and a pleural desis. Thank you for listening.